All right, so we'll talk a little bit about the history of physical agents. So in 400 BC, there was the use of torpedo fish to apply electric shocks to the head and feet of people who complained of headaches and arthritis. Now, this initially came about, we talk about research and studies, and sometimes we do something and it turns out better than we anticipated and it becomes clinical practice. So in 400 BC, right, just prior to 400 BC, a gentleman going to the beach, a little bit of a headache from too much wine the night before, decides to jump into the ocean to cool off and clean up a little bit, and even though he had a headache from partaking in festivities the night before, when jumping into the water, actually collided with a torpedo fish, stood up, and the electric shocks from that torpedo fish immediately took away his headache. From that moment on, electric stim was born. That's the best story I got. It's not necessarily true, but almost believable. In the 17th century, amber was used to generate static electricity to treat skin diseases, inflammation, hemorrhage, and also charged gold leaf to prevent scarring from smallpox lesions. So as early as 400 BC through the 17th century, different types of energy sources were added to the body for medicinal purposes. Now, as much as this is a modality course or physical agents course, you have to understand that I'm not sitting here in my office recording this as if I'm a late night AM DJ where nobody's listening and saying you need to apply physical agents. That's not necessarily the case. Understand that in 1995 and then reiterated in 2005, the American Physical Therapy Association said, without documentation which justifies the necessity of the exclusive use of physical agents and modalities in the absence of other skilled therapeutic or educational intervention, should not be considered physical therapy. Let me translate. A patient that comes in and gets hot pack, ultrasound, e-stim, cold pack, then goes home, without documentation that says they need just this modality and no skilled intervention, that's not physical therapy. So as physical therapy assistants, you need to understand that yes, physical agents could enhance outcomes, but it is not the only means of treatment. Over the years, there have been several approaches to rehabilitation. We talk about impairments and disabilities, and we say that usually function is usually compromised because of an underlying pathology and secondary to impairments. Its loss of function may lead to disability. So several models are out there, the NAGI model, the ICF model, the ICIDH model. So for example, the International Classification of Function and Disability in Health, which we shortened to the ICF model and modified by the ICIDH model, we look at a health condition, disorder, or disease. And in this process, we look at the level at which physical agents have a direct effect on body function and structure, activity, and patient participation. What does this disorder or disease have on our patient's ability to perform their basic activities? How does it affect body functions and structure, and how does it affect their overall participation in activities and function? When we add a modality, how might that change? We also have to consider, and this is what separates out the ICF model from other models, is the idea that you take into account environmental factors and personal factors. In the first part of this, we said that not only is there a tissue healing process, but there's also an emotional process that comes into play with tissue healing. And that's where the ICF kind of separates out. What should we be looking at? Not only the pathology, not only don't label the patient by their injury. Look at their function, look at how it affects their body function and structure, their activities, the environment, and personal factors as well. Right, so we have classification of impairments, disability, and handicap. The Nagy model looks at impairments and functional limitations. The ICF model takes into account the whole person, so to speak: function, disability, health, pathology, emotional components, and personal factors, environment as well. Evidence-based practice. Right? Evidence-based practice requires that clinical practice decisions be guided by the best available relevant clinical research data in conjunction with the clinician's experience and individual patient's pathology and preferences. If you were hurrying to write that down, I'm going to refer you to the Clinical Pearl on page 19 in your textbook. That's where that just came from. We love to say that every clinician practices evidence-based practice. What does evidence-based practice truly mean to you? Because evidence-based practice is more than just reading the literature and applying treatments. Evidence-based practice is about clinical experience. It is about what clinicians feel works versus doesn't work, relating that to the current literature, producing results, reproducing the same results, developing those clinical studies that show these results actually work, do what they say we do. That's evidence-based practice. Table 2.1 talks about levels of evidence. Highest levels of evidence, meta-analysis. Lowest levels of evidence, case reports, right? System reviews, our gold standard, randomized controlled trials, the RCTs. Those are our gold standards. These are planned studies. We randomize the assignment. We blind the subjects. We may blind the testers, right, to get this gold standard. One part of evidence-based practice which we'll come across and we use lightly in this course is a PICO, essentially referring you to page 20, table 2-2. PICO, the P in PICO stands for the patient or population. The question should apply to a specific person or group. For example, adults with low back pain is an example given in your textbook. The I is the intervention. The question should focus on a specific treatment. Is it a certain exercise? Is it a certain modality with specific parameters? What is your treatment? What are you standing on the hilltop saying, my treatment works? What is that intervention? And then a comparison. The comparison, there needs to be some sort of control. So you may do a comparison of the decrease in pain of hot pack application secondary to or compared to ultrasound application. In this study, in a perfect study, we have a group that gets a hot pack, we have a group that gets ultrasound, and then we have a control group where there's no modality applied. The O is the outcome. It should state clearly what is the outcome. Now the PICO is used to design a study or go after a research question. I use the PICO in this course a little bit different in a sense that what I want you to do is analyze data out there, and I want you to be able to tell me what is the patient or population used in the study? What is the intervention used? What is the comparison? Is it a modality versus a control group, or is it multiple modalities being compared? with a specific outcome in mind. What is the outcome of that study? So I use the PICO slightly different than you will going forward. I want you to analyze an article using the PICO format.